Okay, let's unpack this. You know that feeling when you've got like a ton of information on your plate?
Yeah, absolutely.
Maybe it's for something you're prepping for or
Hmm.
just a topic you're really digging into and you want the essential stuff, right? Without getting bogged down in every single
Yeah,
detail.
exactly. You want the core insights.
Well, that's precisely what this deep dive is all about. And today, it's laser focused for you, the learner.
And what's fascinating right off the bat is just how much ground these sources cover.
Yeah.
You've pulled together so many of the foundational pieces of how our bodies work and, well, what keeps us ticking.
Absolutely. So today's mission, and you're already on board, it sounds like, is to navigate this wealth of knowledge. We're looking at everything from that very first breath we take
Mm-hmm.
all the way to some of the most, well, profound human experiences. We're
Right.
talking about the ins and outs of breathing and how our blood gets around,
Circulation, yeah.
that delicate dance of fluids and electrolytes inside us, making sense of diabetes,
A big one.
how medications actually work, managing pain, what happens during surgery, and even touching on, what it means to be spiritually healthy and how we cope with loss.
It's a lot. Think of this as your personal shortcut, maybe, to understanding how it all connects.
Yeah, a cheat sheet almost. Connecting these different areas is really where the insights emerge, I think.
Definitely. What you've gathered gives us a fantastic overview of these interconnected systems. Our goal is to highlight those key aha moments and maybe even uncover a few surprises.
And keep it clear, engaging.
And definitely respecting your time. We don't want to waste anyone's time.
Right. So, with all this in front of us, where should we jump in? How about we start with something so fundamental we often don't even think about it? Breathing.
Oxygenation.
Yeah.
Yeah, the breath of life. Sounds like a great starting point.
Okay, let's dive in.
Well, one of the first interesting things, you might not even realize this, is that your lungs aren't perfectly symmetrical. Yeah, your left lung has 2 lobes, and that's specifically to make room for your heart, which kind of tucks in there. The right lung has 3.
See, right away, something that makes you go, huh. Okay, so we breathe in and out, but it's more than just air moving passively, right?
Hmm.
My notes mention inspiration, breathing in, is active, what's actually doing the work.
Exactly. Inspiration is powered mainly by your diaphragm, that big dome-shaped muscle at the base of your chest, and also the external intercostal muscles, the ones between your ribs.
Okay.
When these muscles contract, they pull down and out, expanding your chest cavity. This creates what's called negative pressure inside.
Negative pressure, like
Yeah.
less than the air outside.
Precisely. Think of it like this. At sea level, the air pressure around you is about 760 millimeters of mercury, right? When you breathe in, the pressure inside your lungs actually drops below that, less than 760.
Ah, okay.
And that pressure difference is what literally sucks the air into your lungs. Then breathing out, expiration, that's usually the easier part. It's mostly passive as those muscles just relax.
Okay, so breathing in is work, actual physical effort. It's described here as the work of breathing, or WOB. That sounds like it should normally be pretty quiet and effortless.
It should be. The effort to expand and contract your lungs, ideally, is minimal. You don't even notice it.
But when does it become noticeable? Or, like, a problem?
Well, if something makes it harder for your lungs to stretch, we call that decreased compliance.
Compliance, like stretchiness.
Yeah, exactly. Like trying to inflate a really stiff balloon. Or if your airways become narrowed, that increases what we call airway resistance. Both of those things significantly ramp up the work of breathing.
Okay, compliance and resistance. Those sound important. Can we dig into those a bit more?
Right.
What affects compliance?
Sure. Compliance is all about how easily your lungs stretch and expand when you breathe in. A healthy lung is like a nice, new, pliable balloon.
Right.
Now, if your lungs have decreased compliance, it's like that stiff balloon. This can happen with conditions where the lung tissue gets scarred, like in pulmonary fibrosis, or filled with fluid, like pulmonary edema.
Makes sense.
Even something like having broken ribs can make it harder for the chest wall to expand, affecting compliance.
What about the opposite? Increased compliance.
Right, that's like a balloon that's been overstretched. It
Yeah.
inflates super easily, but it doesn't snap back well. It doesn't recoil to push the air out effectively. We see that in conditions like emphysema.
Got it. Stiff balloon versus overstretched balloon. Okay, what about airway resistance? What makes it harder for air to actually flow through the pipes, so to speak?
Airway resistance is basically the friction the air encounters as it moves through your airways, nose, mouth, trachea, bronchioles, all the way down. Anything that narrows those passages increases resistance.
Like asthma.
Asthma is a perfect example with the constricted bronchioles, also swelling in the trachea, or even just a lot of mucus blocking things up.
So if your lungs are stiff and your airways are narrow, That sounds like a recipe for really struggling to breathe.
Exactly. The body has to work much, much harder just to get the air in and out. And that uses up a lot more energy.
And you might actually see someone using extra muscles to help.
Yeah, you might see them using their neck and shoulder muscles, we call those accessory muscles, to help lift the chest cage. If someone's relying on those accessory muscles for a long time, it's a clear sign of significant difficulty or dyspnea, and it's actually a very inefficient way to breathe.
My notes mention COPD here. How does that fit in?
In COPD, chronic obstructive pulmonary disease, you often have a nasty combination of increased airway resistance, like chronic bronchitis, and decreased lung elasticity, or problems with compliance, like an emphysema.
Ah, okay.
This leads to air getting trapped in the lungs, what we call hyperinflation. It makes exhaling really difficult. So their work of breathing is constantly high. And yeah, you'll often see them using those accessory muscles.
Okay, so the lungs are doing the heavy lifting, physical work.
Yeah.
But it's the brain calling the shots, right? The notes say the brainstem controls breathing.
That's a crucial point. Yep, the brainstem, specifically areas called the medulla oblongata, and the pons acts like the control center. They constantly monitor the levels of carbon dioxide and oxygen in your blood and automatically adjust your breathing rate and depth, like a thermostat, basically keeping things in balance. Lungs do the work, brain gives the orders.
And lung capacity itself, that varies quite a bit between people, doesn't it?
Oh, absolutely. It's not the same for everyone. Generally, taller people tend to have larger lung volumes. Makes sense, larger chest cavity.
Right.
Also, our lung function typically peaks somewhere between, say, 19 and 40 years old, and then there's a gradual decline as we age. And on average, males tend to have larger lung volumes than females.
Okay, interesting. So moving from the mechanics of breathing to the whole point of it all, getting that oxygen into our blood and delivered around the body, circulation time.
Right. This is where pulmonary circulation comes in. It's where the oxygen exchange actually happens. Your heart's right ventricle pumps the deoxygenated blood, the blue blood, if you like, through the pulmonary artery to the lungs.
And these notes have that handy roadmap of blood flow through the heart. It's quite a journey. Starts with blood coming back from the body.
Yep, via the superior and inferior vena cava into the right atrium.
Then through the tricuspid valve.
To the right ventricle.
Then pumped out through the pulmonary valve.
We're into the pulmonary artery, heading to the lungs.
Lungs do their thing, oxygenate the blood.
Then it comes back via the pulmonary veins into the left atrium.
Through the bicuspid or mitral valve.
Into the powerhouse, the left ventricle.
Which pumps it out through the aortic valve.
And into the aorta to supply the whole body. Phew. That mnemonic, some real teachers play perfect learning games like bad students always aim, is actually pretty helpful for remembering that sequence.
It really is. And all that pumping adds up to cardiac output. The notes say normal is about 4 to 8 liters per minute. How does that relate to getting oxygen delivered?
Cardiac output is huge for oxygen delivery. It's the total amount of blood your heart pumps out each minute. Simple equation. Stroke volume times heart rate.
Stroke volume being the amount per beat.
Exactly. And stroke volume is affected by a few things. Preload, which is how much the heart muscle stretches before it contracts. Afterload, the resistance the heart has to pump against. And contractility, just how strongly the heart muscle itself can squeeze.
Okay.
So anything affecting those will affect cardiac output. Interestingly, if your heart rate gets too fast, say consistently over 160 beats per minute, cardiac output can actually drop.
Why is that?
Because the heart's chambers, the ventricles, don't have enough time to fill up completely with blood between beats. Less filling means less blood pumped out with each beat, even if the rate is high.
Yeah, makes sense. And the heart's electrical system, that's the conductor, making sure it all happens in rhythm, starting with the SA node.
Precisely. The sinoatrial node, or SA node, is the heart's natural pacemaker. It kicks off the electrical impulse.
Right.
That signal spreads through the atria, making them contract. Then it pauses briefly at the AV node, the atrioventricular node, before traveling down the bundle of His, through the bundle branches, and finally out to the Purkinje fibers in the ventricle walls.
Causing the ventricles to squeeze.
Exactly. It's this perfectly timed, coordinated electrical sequence that ensures the efficient pump function we need for good oxygen delivery. Squeeze and relax, squeeze and relax.
Okay, so what if someone isn't getting enough oxygen? We need to give them extra. We've got different delivery systems mentioned here. Low flow versus high flow.
Yeah, that's a key distinction. Low flow systems, like your standard nasal cannula or a simple face mask, deliver supplemental oxygen. But the actual percentage of oxygen the person inhales gets mixed with room air and can vary quite a bit depending on how they're breathing. Fast, slow, deep, shallow.
Okay.
High-flow systems, like a high-flow nasal cannula or a Venturi mask, are designed to deliver a much more precise and consistent concentration of oxygen, often at higher flow rates, regardless of the patient's breathing pattern.
Got it. And there's a really important point here about patients with COPD and oxygen therapy, something about being careful.
Yes, absolutely critical. For some individuals with chronic COPD, their bodies have adapted to having higher levels of carbon dioxide in their blood. Their primary drive to breathe might actually switch from being stimulated by high CO2, like in most people, to being stimulated by low oxygen levels.
Okay.
So if you give them too much supplemental oxygen, it can potentially reduce their drive to breathe. This can lead to them retaining even more carbon dioxide, a condition called hypercapnia or CO2 retention, which can cause respiratory acidosis. It's dangerous.
No. So you need to be careful.
Extremely careful. That's why the target oxygen saturation for many COPD patients is often a bit lower, typically around 88 to 92%. We usually start with low-flow oxygen and monitor them very closely. High flow might be used, but with caution and continuous monitoring.
Okay. And then we have things like CPAP and BiPAP.
Yeah.
Those aren't breathing tubes, right?
Correct. CPAP, continuous positive airway pressure, and BiPAP, bilevel positive airway pressure, are forms of non-invasive ventilation. They use a mask over the nose or face to deliver pressurized air.
What do they do?
They help keep the airways open, making breathing easier. CPAP provides one continuous pressure level, great for things like sleep apnea. BiPAP provides two levels, a higher pressure when breathing in, a lower pressure when breathing out, which can be helpful for certain types of respiratory failure. They can sometimes help people avoid needing an artificial airway, like an endotracheal tube.
And the AMDU bag. That sounds like an emergency thing.
It is. An AMBU bag is a manual resuscitator. It's a self-inflating bag attached to a mask or an artificial airway. You squeeze the bag by hand to deliver breaths to the patient in an emergency, like during CPR or if their ventilator stops working.
Okay. Now, keeping lungs healthy isn't just about oxygen delivery. It's also about maintenance, right? Like keeping them expanded. Ambulation, just walking around, is listed as crucial.
Absolutely crucial. Immobility is a huge risk factor for lung complications, things like atelectasis, that collapse of the tiny air sacs we mentioned.
Right. Atelectasis.
And pneumonia. Just getting up and moving helps keep the lungs inflated, mobilizes secretions so you can cough them up, and generally improves overall lung function.
And even just how you sit in bed matters. Semi-Fowler's position, about 45 degrees, is mentioned as best.
Yeah, sitting up at least partially, like in a semi-Fowler's position, allows the diaphragm to move more freely because there's less pressure from the abdominal organs pushing up. This makes it easier to take deeper breaths and expand the lower parts of the lungs.
Then there's this little gadget, the incentive spirometer. Patients use it to practice deep breathing. Looks simple, but the benefits listed seem pretty significant.
It is simple, but incredibly effective, especially after surgery or for people on bed rest. It gives patients visual feedback to encourage them to take slow, deep, sustained breaths.
How does it work exactly?
Basically, you sit upright, exhale normally, seal your lips around the mouthpiece, and then inhale slowly and deeply, trying to keep the little ball or piston elevated for as long as possible, usually aiming for 3 to 5 seconds. Then you exhale slowly. Repeating this, say, 10 times every hour while awake, really helps prevent atelectasis, expand those collapsed air sacs, improve oxygen levels, and loosen secretions. Coughing after using it helps clear things out. Big benefits for reducing post-op risks.
And we touched on non-invasive ventilation, like CPAP, BPAP, potentially preventing intubation. But what happens when someone does need more intensive support? Invasive mechanical ventilation.
Right. Invasive mechanical ventilation is a life support measure. It means putting in an artificial airway, usually an endotracheal tube inserted through the mouth or nose into the trachea, or sometimes a tracheostomy tube inserted directly into the neck and connecting the patient to a ventilator machine.
And the machine breathes for them.
It can assist their breathing. The main goals are to improve gas exchange, get oxygen in, CO2 out, increase lung volume, and reduce the patient's work of breathing when they just can't manage on their own.
There are different modes mentioned. Assist control, SIMV, pressure support. Sounds complex.
It can be. The modes basically determine how much work the ventilator does versus how much the patient does. Assist control often provides full support, delivering a set breath volume or pressure with each breath, whether triggered by the patient or the machine. SIV, synchronized intermittent mandatory ventilation, delivers some mandatory breaths, but allows the patient to take spontaneous breaths in between. Pressure support just gives a little boost of pressure during the patient's own spontaneous breaths to make it easier. The mode is chosen based on the patient's specific needs.
But there are risks, right? Like VAP, ventilator-associated pneumonia.
Yes, VAP is a significant risk. That artificial airway bypasses the body's natural filtering and defense mechanisms in the upper airway, making it easier for bacteria to get into the lungs and cause infection. Meticulous oral care and specific ventilator bundles are used to try and prevent it.
Okay, last thing in this section. Chest tubes. Used for things like a collapsed lung.
Exactly. A chest tube is inserted into the pleural space, that potential space between the lung lining and the chest wall lining. It's used to drain air, like in a pneumothorax or collapsed lung, or fluid like blood hemothorax or pus emphysema.
And the goal is to let the lung re-expand.
Precisely. Removing the air or fluid allows the lung to inflate fully again. There are a few key principles for managing them.
Like keeping the system closed and below the chest level.
Absolutely critical. It needs to be a closed system to prevent outside air from getting sucked back into the pleural space, and keeping the drainage collection unit below the level of the patient's chest uses gravity to help the drainage flow out.
What should you look for in the system? Bubbling, idling.
You might see gentle intermittent bubbling in the suction control chamber. If suction is being used, that's usually normal. In the water seal chamber, you should ideally see tidling, the water level rising and falling slightly as the patient breathes in and out. That indicates the system is patent and reflecting the pressure changes in the chest.
What if there's constant bubbling in that water seal chamber?
That usually means there's an air leak somewhere, either from the patient's lung or somewhere in the tubing or connection. That needs investigation.
Got it. And report cloudy or bloody drainage. Avoid kinks. Don't clamp it.
Right. Report any significant changes in the amount or character of the drainage. Keep the tubing free of kinks or dependent loops that could obstruct flow. Reposition the patient frequently to help drainage. And generally, you should not clamp a chest tube, especially if it's actively draining air or fluid, because that can cause pressure to build up dangerously in the chest, attention pneumothorax.
Okay, and finally, suctioning. That's for clearing secretions when someone can't cough effectively.
Exactly. If a patient has secretions they can't clear on their own, suctioning may be needed to maintain a clear airway.
Key points seem to be using negative pressure carefully, only on withdrawal, and for a short time.
Yes. We use the smallest effective catheter size to minimize trauma. Apply suction, usually less than 120 millimeter Hg for adults, only while withdrawing the catheter, rotating it gently. And limit each suction pass to about 10-15 seconds maximum to avoid removing too much oxygen.
And sterile technique for the trachea is vital.
Absolutely essential for endotracheal or tracheostomy suctioning to prevent introducing infection deep into the lungs. Clean technique is usually fine for suctioning the mouth or nose. There are also open systems, new sterile catheter each time, and closed systems, reusable sterile catheter in a protective sheath, often used for ventilated patients.
Oh, okay. That's a really deep dive into oxygenation. I feel like I have a much better handle on the breath of life now.
It's fundamental stuff.
Let's shift gears to something equally critical. The body's internal chemistry set. Fluid, electrolyte, and acid-base balance. This sounds like a really delicate balancing act.
It absolutely is. Think of it as maintaining the perfect internal environment for all our cells to function properly. It's incredibly complex, but essential.
Let's start with electrolytes. The notes list normal ranges: sodium 135, 145, potassium 3.5, 5.0, calcium 9.0, 10.5, magnesium 1.3, 2.1. It seems important to know the signs if these are off.
Knowing the numbers is helpful, but yeah, understanding the basic signs and symptoms of imbalances hypo too low or hyper too high is even more crucial in practice, because these imbalances can cause real problems.
Like the note that says high sodium often goes with low potassium, and low potassium is bad for the heart.
That's a really important relationship, the sodium-potassium pump and their inverse balance sometimes. And yes, potassium is particularly critical for heart function. Even small deviations from that narrow 3.5-5.0 range can affect the heart's electrical activity and pumping ability. Low potassium can definitely decrease cardiac output.
And you should never push potassium 5.
Absolutely never. Potassium chloride given IV must always be diluted properly and infused slowly, usually via pump. A rapid 5V push of potassium can cause fatal cardiac arrhythmias. Very, very dangerous.
Okay, duly noted. Then there's acid-base balance. PaSO2 is respiratory, HCO3 is metabolic, and the goal is that tight pH range of 7.35 to 7.45, like the body's Goldilocks zone.
Exactly. PaSO2, the partial pressure of carbon dioxide in arterial blood, reflects how well the lungs are blowing off CO2, which acts as an acid. HTO3, bicarbonate, is regulated by the kidneys and acts as a base, a buffer. Maintaining that precise pH balance is vital for enzymes, cell function, everything.
Let's talk fluid imbalances, ECV deficit, too little isotonic fluid, and ECV excess, too much. What causes these and what are the signs?
ECV deficit, think dehydration or hypovolemia, can happen from decreased intake or increased loss, like vomiting, diarrhea, heavy sweating, diuretic use, bleeding, or burns.
Fine.
You might see dizziness when standing up, orthostatic hypotension, dry skin and mouth, fatigue, muscle cramps, dark concentrated urine. More severe signs include tachycardia, fast heart rate, a weak throaty pulse, flat neck veins when lying down, poor skin turgor where pinched skin stays tented, and maybe decreased urine output or confusion.
And ECV excess, fluid overload.
That can happen from getting too much IV fluid, eating way too much salt, or conditions where the body holds on to fluid like heart failure, liver cirrhosis, or kidney failure.
Signs for that one.
Look for sudden weight gain, edema, or swelling, especially in legs, ankles, sometimes hands and face, distended neck veins even when sitting upright, and sometimes crackles or wet sounds in the lungs on auscultation.
Okay, so how do we get fluids in when needed? 4 V's. The notes mention using larger veins for certain things.
Yeah, generally if you need to give large volumes quickly, or if the fluid is thick like blood or hypertonic, or if it's a medication known to irritate veins, a larger vein is better. Proximal veins, closer to the body's core, are often preferred for longer-term therapy.
Any veins to avoid or challenges?
Definitely avoid arms on the side of a mastectomy or with dialysis access like a shunt or fistula. Avoid bruised or injured limbs. Older adults can be challenging as their veins might be more fragile or roll easily. Scalp veins are sometimes used in infants.
And IVs aren't without risks. Complications like infiltration, phlebitis, what are those?
Right. Circulatory overload is giving fluid too fast. Infiltration is when the IV needle or catheter slips out of the vein and the fluid leaks into the surrounding tissue. It usually looks cool, swollen, maybe pale and puffy.
Okay.
Extravasation is similar, but it involves a vesicant medication, something that can actually damage the tissue. That can be much more serious, causing blistering or tissue death. Phlebitis is inflammation of the vein itself, often looks red, warm, tender along the vein track. Then there's infection risk at the site, potential for air embolism if air gets in the line, and bleeding.
Central lines are also mentioned for bigger jobs, but higher risks.
Exactly. Central venous catheters go into large veins in the chest or neck, or sometimes peripherally inserted central catheters, PICCs, go in via the arm but end up in a large central vein. They're used for large volumes, long-term therapy, irritating meds, parenteral nutrition, dialysis access.
But the risks?
Insertion risks include hitting an artery, puncturing the lung, pneumothorax, bleeding. Ongoing risks include infection, central line-associated bloodstream infection, or CLAB-SI, blood clots, air embolism. Placement always needs X-ray confirmation before use.
So infection prevention is huge for all IVs. Hand hygiene, keeping the system sterile.
Paramount. Meticulous hand hygiene before touching any part of the system. Strict aseptic technique when changing tubing, dressings, accessing ports, scrubbing the hub. It's all crucial to prevent bloodstream infections.
Blood transfusions also come up here. The danger of ABO incompatibility is stressed. Preventable, but deadly.
It's the most severe type of transfusion reaction, and yes, thankfully, almost entirely preventable with rigorous safety checks. It involves meticulous patient identification using at least 2 identifiers and double-checking the blood product label against the order and the patient's blood type information at the bedside before starting the transfusion. Careful monitoring during and after is also key.
Quick rundown on IV fluid types: isotonic, hypotonic, hypertonic. Use depends on the problem.
Correct. Isotonic fluids, like normal saline or lactated ringers, have a similar concentration to body fluids, so they mainly expand the extracellular volume. Good for general fluid replacement. Hypotonic fluids, like half-normal saline, have fewer solutes, so water moves into cells used cautiously for cellular dehydration. Hypertonic fluids, like 3% saline, have more solutes, pulling water out of cells used very carefully, often in ICUs, for specific things like reducing brain swelling. The choice depends entirely on the patient's specific imbalance.
And last here, fluid restriction and tracking intake and output. INO. Intake should equal output?
Ideally, over time, yes. INO monitoring is vital for patients at risk for fluid imbalance. Intake is everything liquid that goes in oral fluids, IVs, tube feeds, liquid meds. Output is everything liquid urine, liquid stool, emesis, drain output.
Who measures it?
Measuring can often be delegated to unlicensed assistive personnel. UAPs. But the RN is responsible for interpreting the data, looking at the trends over 24-48 hours, ensuring accuracy, and intervening if there's a significant imbalance. Recording should happen at least every 8 hours, or more often if needed.
Okay, internal chemistry lesson complete. Let's switch now to diabetes mellitus, understanding blood sugar. The big takeaway seems to be that consistently high blood sugar is damaging long-term.
That's the core issue. Diabetes is characterized by hyperglycemia, high blood sugar, because of defects in either insulin secretion by the pancreas or the body's ability to use the insulin it makes, insulin action, or both. And yes, over time, that high glucose damages blood vessels and nerves, leading to complications in the eyes, kidneys, nerves, heart.
And insulin is the key hormone from the pancreas that lets cells use glucose for energy.
Exactly. Think of insulin as the key that unlocks a cell door, letting glucose from the bloodstream enter the cell to be used for energy or stored. Without enough working keys, glucose piles up in the blood.
The notes list common signs: fatigue, blurred vision, maybe losing weight without trying, numbness, slow healing, and those classic 3Ps.
Right. Fatigue and blurred vision are common. Unexplained weight loss can happen, especially in type 1, as the body breaks down fat and muscle for energy since it can't use glucose well. And the 3Ps, polydipsia, excessive thirst, because high blood sugar pulls water into the urine, leading to dehydration.
Polyuria.
Polyuria, frequent urination, for the same reason the kidneys are trying to dump the excess glucose and water follows it. And polyphagia, excessive hunger, because even though there's lots of glucose in the blood, the cells are starving for energy.
And the two main types, type 1 and type 2. What's the core difference?
The cause of the insulin problem, type 1, about 5–10% of cases, is autoimmune. The body's immune system attacks and destroys the insulin-producing beta cells in the pancreas, so they produce little or no insulin. Usually diagnosed in younger people, requires insulin for survival, not caused by lifestyle.
Okay. And type 2?
Type 2 is the vast majority, 90–95%. It starts with insulin resistance. The cells don't respond well to insulin's key. The pancreas tries to compensate by making more insulin, but eventually it may not be able to keep up, and insulin production can decrease too. Strongly linked to genetics, obesity, inactivity, usually develops in adults, but we're seeing it more in kids now.
Management for type 2 often starts with diet and exercise, but might need meds.
Yes. Lifestyle changes are foundational, but many people with type 2 eventually need oral medications or even insulin to manage their blood sugar. Metformin is often a first-line drug.
Ah, yes. The notes mention metformin often causes diarrhea, which is normal, and to stay hydrated.
That's a very common side effect, especially initially. It usually improves over time, but yeah, staying hydrated is important. Metformin helps reduce liver glucose production and improves insulin sensitivity.
Okay, so hyperglycemia is high blood sugar. Besides the 3Ps, what else might point to it?
Blurred vision, maybe more frequent infections, skin, yeast infections, UTIs, ongoing fatigue, headaches. You might also find glucose in the urine, glycosuria, or ketones in the urine, ketonuria, if the body's burning fat for fuel.
And the flip side, hypoglycemia, blood sugar less than 70? That sounds like it needs quick action.
Absolutely. Hypoglycemia can be dangerous. Symptoms often come on fast: shaky, nervous, anxious, sweaty, fast heartbeat, intense hunger, blurred vision, headache, dizzy. Severe cases can lead to confusion, seizures, loss of consciousness.
How do you treat it? The 15/15 rule.
That's the standard for conscious patients with mild, moderate hypo. Give 15 grams of fast-acting carbs like 4-ounce juice, glucose tabs, hard candy, wait 15 minutes, recheck blood sugar. If still low, repeat. Once above 70, follow up with a snack containing protein and carbs to keep it stable.
What if they're unconscious or can't swallow?
Then they need help. Maybe an injection of glucagon, which tells the liver to release stored glucose, or IV dextrose given by healthcare professionals.
There are also these acute hyperglycemic crises, DKA and HHS. Sounds serious.
They are medical emergencies. DKA, diabetic ketoacidosis, is more common in type 1. Severe insulin deficiency leads to rapid fat breakdown, producing ketones, which makes the blood acidic. Blood sugar is high. Ketones in urine, often fruity breath odor, comes in relatively fast.
Treatment.
Hospitalization.
Yeah.
Focus on ABCs, airway, breathing, circulation, IV fluids for rehydration, IV insulin to lower sugar and stop ketone production, electrolyte correction, especially potassium.
And HHS.
Hyperosmolar hyperglycemic state, more common in type 2, characterized by extremely high blood sugar, often 600, leading to severe dehydration and altered mental status, but usually without significant ketoacidosis. Develops more slowly over days or weeks.
Treatment for HS.
Also, hospitalization. Main focus is aggressive rehydration with IV fluids, plus insulin therapy and electrolyte monitoring.
Long-term complications of diabetes are split into macrovascular and microvascular.
Right. Macrovascular means damage to large blood vessels, increases risk of heart attack, stroke, peripheral artery disease, poor circulation in legs, feet. Microvascular is damage to small blood vessels, affects eyes, retinopathy can cause blindness, kidneys, nephropathy can cause failure, and nerves, neuropathy causing pain, numbness, especially in feet.
And finally, sick day rules for people with diabetes. Important stuff.
Very important. When ill, blood sugar can fluctuate wildly. Key rules: continue taking diabetes meds. Dose might need adjusting, check with doctor. Monitor blood glucose more often. Drink plenty of sugar-free fluids. Know when to call the doctor or go to the ER.
When is ER necessary?
If blood sugar stays very high or very low despite treatment, if they can't keep liquids down, trouble breathing, can't eat for 24 hours, prolonged vomiting, diarrhea, persistent fever, altered mental status, and foot care is always vital. Check feet daily.
Wow, okay. Diabetes covered.
Yeah,
Let's switch to another fundamental, medication administration. The safe and right way to give meds.
absolutely critical area. Patient safety hinges on doing this correctly every single time.
First up, routes. Oral, topical, parenteral. Injections like ID, sub-Q, IM, 4, inhaled. Absorption rates vary. 4 is fastest.
That's right. 4V goes directly into the bloodstream, so it's the fastest onset. Inhaled is usually next fastest. Then oral, which has to go through the GI tract. Topical, absorbed through the skin, is generally the slowest. The mnemonic PIOT, parenteral, inhaled, oral, topical, can help remember the general speed order.
And you need an order to change the route.
Always. You can't just decide to give an oral med 4 or vice versa. Need a specific order from the prescriber.
Then we have pharmacokinetics, ADME, what the body does to the drug.
Yep. ADME stands for absorption, getting into the bloodstream. Distribution, traveling to the target site. Metabolism, chemically changing the drug, often in the liver. And excretion, removing it, usually via kidneys.
And pharmacodynamics, AT, what the drug does to the body.
Right. Think AT, therapeutic effects, the desired outcome, and adverse effects, unwanted effects, side effects, allergies, toxicity, etc. Both kinetics and dynamics can be affected by things like age. Older adults often metabolize and excrete drugs slower, increasing toxicity risk and other health conditions or drug interactions.
Okay, let's talk injections. Aseptic technique is key, obviously. Needles and syringes.
Yep. Sterile technique prevents infection. Know your syringe types. Luer lock screws on, non-luer lock slips on. Needle parts. Hub connects to syringe, shaft is the length, bevel is the slanted tip. Gauge is diameter, bigger number, smaller needle. Length varies by injection type and patient size.
Let's run through the types. Intradermal, ID, just under the skin.
Into the dermis, that top layer of skin. Tiny volume, 0.1, 0.2 ml. Small needle, 25-27 gauge. Shallow angle, 10-15 degrees. You should see a little bubble or blub form if done right. Used for TB tests, allergy testing.
Subcutaneous, sub-Q, into the fatty tissue.
Right, below the dermis. Common sites, abdomen, back of arms, thighs, upper buttocks. Volume, usually 0.5 to 1 millimole. Needle, 25-30 gauge, maybe half to 1 inch long. Pinch the skin if you get 2 inches, go in at 90 degrees. If only 1 inch, use 45 degrees. Crucial to rotate sites for frequent injections like insulin,
Why rotate?
to prevent lipohypertrophy, lumps of fat, or apoatrophy, dense, which can affect how the medication is absorbed.
Makes sense. Then intramuscular, IM,
Yep.
into the muscle itself.
Yep, 90-degree angle straight into the muscle. Absorbs faster than sub-Q due to blood supply. Needle gauge usually 18-25, length 1 to 3 inches depending on site and patient size.
How much can you inject IM?
Volume limits are important. Adults generally 2-5 millimole max per site, but ideally less than 4 millimole. Children, elderly, thin folks, maybe 2 millimole. Small kids 1 millimole, infants 0.5 millimole. Spread large volumes over multiple sites if needed.
Common sites. Deltoid, ventrogluteal.
Deltoid, upper arm, good for smaller volumes, 2 milliliter, often vaccines. Ventrogluteal, hip area, is considered safest for larger volumes, 2 milliliter, as it avoids major nerve vessels. Vastus lateralis, outer thigh, common for infant vaccines. Rectus humerus, front thigh, less common now.
What about aspiration? Pulling back to check for blood.
Practice varies. It's not universally recommended anymore, especially for vaccines. Always check your facility's policy on aspiration for IM injections.
And intravenous, directly into the vein. Scrub the hub is emphasized again. Why so critical?
Because that 5E hub or port is a direct gateway to the bloodstream, not scrubbing it vigorously with alcohol or chlorhexidine for the recommended time, like 15-30 seconds, and letting it dry allows bacteria to be pushed right in, causing potentially deadly infections every single time.
How are 5 amines given? Push, primary, secondary?
IV push, IVP, is a concentrated dose given quickly. Primary infusion is the main IV fluid, maybe with continuous meds. Secondary or IV piggyback, IVPD, is a smaller bag of medication hung higher, infused intermittently through the primary line. Rates are set in drops per minute, GT-min, or ml per hour, ml/hr.
Insulin specifics. Orange cap syringe, measured in units. Crucial.
Absolutely crucial. Insulin syringes are marked in units, not ml. Only use an insulin syringe for insulin. Never convert. Serious errors can happen otherwise. And rotate those sub-Q sites.
Moving to medication orders, they need a lot of specific info to be safe.
Yes, a complete order is vital. Needs: patient's full name, medication name, generic preferred trade, okay. Dosage, clear numbers, no trailing zeros. Route, time frequency, date time order written, prescriber's signature, and ideally, the purpose indication for the med.
Lots of order types. Routine, PRN, stat. Now, how fast is stat?
Routine standing are ongoing. PRN is as needed, based on specific criteria. Protocols allow nurses to act based on pre-approved conditions. One time is just once. Stat means immediately. ASAP, drop everything safely. Now is urgent, but usually within about 90 minutes, not quite as emergent as stat.
Phone verbal orders need readback.
Yes, always read back and verify, RBAV, for phone, fax, or verbal orders to prevent miscommunication. Verbal orders should be rare, only emergencies, and signed ASP. Electronic orders, CPOA, help reduce errors. Prescriptions are for outpatient use.
4V sites again. Peripheral, hand-arm, short-term versus central, long-term need special training, X-ray confirmation.
That sums it up well. Central lines access bigger veins, handle more caustic meds or long therapies, but require more specialized care and carry higher risks like infection and pneumothorax.
Medication errors are a huge concern. The advice, step up and speak up.
Absolutely. Everyone involved is a safety net. If something seems wrong, dose, drug, route, patient, anything, question it. Speak up immediately. Patient advocacy is key. We're often the last check. And remember, patients have the right to refuse meds, document it, and notify the provider.
And the bedrock principles. The 7 rights and 3 checks.
Yes, the 7 rights. Right patient, use 2 identifiers, right medication, right dose, right route, right time, right right documentation, and the 3 checks. Check the med against the order when pulling it, when preparing it, and at the bedside before giving it. Following these religiously prevents so many errors.
Okay, solid overview of meds. Now a brief mention of complementary, alternative, and integrative therapies. Some need special training.
That's right. These cover a huge range of practices outside conventional Western medicine: acupuncture, massage, herbs, meditation, yoga, etc. Some, like acupuncture or herbalism, definitely require specialized training and licensure. Integrative health aims to combine evidence-based complementary therapies with conventional care.
Meditation mentioned specifically has pros and cons.
Yeah, meditation can be great for stress reduction, focus, etc. But like any intervention, it might not be suitable for everyone or in every situation. It's important for us as nurses to understand why patients might be using these therapies and to discuss them openly.
Next, spiritual health. Benefits like less pain anxiety, better quality of life are noted. And spirituality versus religion.
Yes, addressing spiritual needs is part of holistic care. Spirituality is broader about finding meaning, purpose, connection. Religion is usually a more organized system of beliefs and practices. Supporting a patient's spiritual well-being can positively impact their coping, hope, and overall health outcomes.
There's a tool for spiritual assessment, FICA.
Yes, FICA is a common mnemonic. Faith belief. What gives your life meaning? Importance. How important is this to you? Community. Are you part of a spiritual community? How would you like us to address these issues in your care? It helps guide a sensitive conversation. Key nursing actions are establishing presence, just being there, listening, and supporting a healing relationship.
Then, the sensitive topic of loss and grief. Different types of loss. Necessary, situational.
Loss is universal. Necessary losses are part of life changes, like kids leaving home. Maturational losses are expected with development, toddler separation anxiety. Situational losses are sudden, unpredictable, job loss, accident. Actual loss is tangible, death of person, loss of limb. Perceived loss is felt by the person but maybe not obvious to others, loss of confidence.
And grief is the response, highly individual.
Exactly. Grief is the personal, emotional, physical, cognitive response to loss. There's no single right way. Symptoms can be physical, fatigue, appetite changes, emotional, sadness, anger, guilt. cognitive, trouble concentrating. It's unique to each person and situation.
Therapeutic communication is key for support. Open questions, listening, silence.
Absolutely. Don't avoid the topic. Use open-ended questions. Tell me how you're feeling. Listen actively, without judgment. Allow silence. It gives space for reflection. Offer empathy. That sounds incredibly difficult. Sometimes just offering your presence, maybe appropriate touch, is enough. Avoid cliches or minimizing their pain.
Advanced directives are mentioned here too. Living wills, durable power of attorney for healthcare.
Yes, these are important for planning end-of-life care. A living will states wishes about medical treatments if unable to communicate. A durable power of attorney for healthcare designates someone to make health decisions if the person becomes incapacitated. Having these helps ensure wishes are followed and reduces burden on loved ones.
Okay, let's tackle pain management. Systematic assessment considering quality of life is stressed. Patient's report is key.
Patient self-report is the gold standard. Pain is whatever the experiencing person says it is, existing whenever they say it does. Assessment needs to be systematic. Onset, location, duration, characteristics, sharp, dull, burning, intensity, using a scale, pattern, relieving aggravating factors, contributing symptoms, impact on life.
Nonverbal cues matter, but don't tell us intensity.
Right. Nonverbal cues like grimacing, guarding, restlessness can indicate pain is present, but they don't reliably measure intensity. Someone might be stoic, but in severe pain. Always listen to their words first, if possible.
Special considerations for older adults. They might underreport.
Yes, older adults may underreport due to beliefs, pain is normal aging, fear of addiction, cognitive issues, or not wanting to complain. Pain is not normal aging. We need to assess actively. Cultural factors also influence expression. Some cultures are more stoic, others more expressive. Be culturally sensitive, don't assume.
Pain clearly impacts quality of life, self-care, work, social life.
Hugely. Chronic pain especially can be debilitating, affecting ability to function, mood, sleep, relationships. Effective pain management is crucial for overall well-being.
Treatments include analgesics, non-opioids, opioids, adjuvants, and non-pharmacological methods.
Yes. Analgesics are the mainstay. Non-opioids, acetaminophen and SAAs for mild-moderate pain. Opioids for moderate-severe pain. Adjuvants are meds for other conditions that also help pain, like antidepressants for neuropathy. Non-pharmacological includes heat-cold, massage, 10NS, acupuncture, relaxation, cognitive behavioral therapy, CBT. Often a combination approach works best.
What's PCA?
Patient-controlled analgesia. An IV pump programmed with safety limits that allows the patient to push a button to self-administer small doses of pain medication, usually opioids, when they feel they need it, gives them control.
Okay, nearly there. Last major section. Perioperative nursing. Care before, during, and after surgery. Different roles.
Yep. Pre-op phase. Preparing the patient, assessment, teaching, consent, checklist. Intra-op phase. Inside the OR, roles like the circulating nurse manages the room, patient advocate, and the scrub nurse tech handles sterile instruments. Post-op phase. Recovery, starting in the PSU, post-anesthesia care unit, monitoring for complications, managing pain, getting them stable.
Surgeries are classified different ways. Emergency versus elective, risk, purpose.
Wait. Urgency. Emergency, immediate, urgent within 24 to 48 hours. Elective, planned. Risk, high versus low. Purpose, ablative, remove disease part. Diagnostic biopsy. Palliative, relieve symptoms. Reconstructive, cosmetic transplant.
What's the ASA classification?
American Society of Anesthesiologists Physical Status Classification. Rates patients' pre-op health from I, healthy, to C, be brain dead organ donor. Helps assess surgical risk.
Anesthesia types. General, regional, local, moderate sedation. General means unconscious.
Correct. General. Loss of consciousness requires airway support, has phases. Induction going under, maintenance keeping under, emergence waking up. Regional. Numbs a specific body area, spinal, epidural. Local. Numbs just the incision site. Moderate, conscious, sedation. Sleepy, relaxed, pain-free, but can respond and breathe independently.
What factors affect surgical outcomes? Age, other conditions?
Lots of things. Age. Very young gold, higher risk. Type of wound, pre-existing conditions, heart, lung, kidney disease, diabetes, mental status, medications they take, habits, smoking, alcohol, allergies, nutrition, even home support influences recovery.
Post-op priorities are critical. Airway first.
Always ABCs first. Airway patency, breathing adequacy, rate, depth, O2 sat, circulation, vitals, perfusion, bleeding. Then level of consciousness, LOC, pain management, checking the surgical site, dressing, drainage, monitoring intake and output. Urine output 30 milliliter is key. Preventing nausea, vomiting.
And preventing complications is big too. Deep breathing, moving.
Huge. Encourage deep breathing, coughing, maybe using that incentive spirometer, to prevent pneumonia telangiectasis. Early ambulation helps prevent blood clots, DVTs, and improves lung function. Infection prevention at the surgical site is also vital.
And finally, just a note on dosage calculations and knowing lab values.
Yes, fundamental skills. Need to calculate doses accurately for all routes, PO, injections, IV infusions based on weight or hourly rates, and understanding normal lab values, potassium, sodium, magnesium, calcium, pH, PO2, PaSO2, HCO3, glucose, A1C, and what deviations might mean is essential for assessment and safe care.
Wow. Okay. We have really covered a tremendous amount of ground in this deep dive. This was all tailored to give you, the learner, a really solid, comprehensive overview of these interconnected health concepts.
It's a lot, but hopefully seeing it laid out helps connect the dots, from breathing and circulation.
Right, down to fluids, electrolytes, diabetes, meds, pain, surgery, even spiritual health and loss. You should have a much broader picture now.
And thinking about those interactions is key, like how does poor lung function affect cardiac output?
Or how does diabetes mess with fluid balance? Those connections deepen the understanding, right?
Absolutely. It shows how the body works as a whole system.
We really hope this has sparked some aha moments for you and given you a clearer picture of this essential knowledge if anything we discuss really grabbed your interest.
Yeah, definitely dig deeper into that specific area. What stood out most to you? What questions do you still have?
That exploration is where the real learning happens.
So maybe a final thought to leave you with. Just consider how seemingly small physiological changes, a tiny shift in an electrolyte, a slight narrowing in an airway, can actually ripple outwards and have really wide-ranging effects on the whole body.
It really speaks to the incredible complexity.
And the delicate interconnectedness of human health. It's truly amazing. Keep exploring, keep learning.
And thanks for diving deep with us today.